Welcome, everyone. My name is Ari Acosta. My pronouns are she, ella, and I am the Behavioral Health Equity Specialist for the South-Southwest Mental Health Technology Transfer Center, or as we call it, AMH-TTC. For those calling in or in listening only mode, I'm a Latina wearing glasses, and I'm wearing a black shirt with the official AMH-TTC blue Zoom background. I'm very pleased to welcome you all to our webinar series titled The Cultural Formulation Interview, a collaborative storytelling approach to clinical care. And for today's first session, the value of person-centered cultural assessment in clinical practice. This presentation was prepared for the AMH-TTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed in the presentation are the views of our speakers and do not reflect the official position of the Department of Health and Human Services, or SAMHSA. The AMH-TTC network uses affirming, respectful, recovery-oriented language in all of our activities. We are dedicated to providing events where everyone feels welcome. We invite everyone here today to help us achieve a safe, respectful, inclusive, and positive environment for learning. Essentially, we ask that you be kind to one another during this session. To start us off, I would like to cover a few housekeeping items. First, we have made every attempt to make today's presentation secure, but if we need to end the presentation unexpectedly, we'll follow up using your registration information. All attendees are in listen-only mode and cannot share video. If you have a question for our speakers, we ask that you submit it through the Q&A pod. We have our awesome Mordecai and Jennifer monitoring the pod, and we will do our best to respond to as many questions as time allows. If you have a comment or want to share research with all the attendees, please use the chat box. A certificate of attendance with 1.5 CEUs will be emailed to you by the end of the day. Make sure to check your spam folder. Attendees are responsible for checking with the licensing or credentialing board to ensure acceptance of the CEUs issued. At the end of the session, you will be redirected to a brief survey to complete. Please take your time to complete it. It's very important for us. And the recording and the slides will be posted on our website a few days after the event for you to review and to share. This webinar is brought to you by the South-Southwest Mental Health Technology Transfer Center, an initiative founded by the Substance Abuse and Mental Health Services Administration to provide free training and ongoing consultation to all professionals that serve individuals with mental health challenges. Our region is Region 6, covering the states of Texas, Oklahoma, New Mexico, Arkansas, Louisiana, and our tribal communities. The South-Southwest AMH-TTC is a project of the Texas Institute for Excellence in Mental Health, which is housed at the School of Social Work at the University of Texas at Austin. All right, so we have two amazing speakers with us today who will get us started with session number 1 of this series. First, we have Dr. Roberto Lewis-Fernandez, MD. Dr. Roberto is a professor of clinical psychiatry at Columbia University, director of the New York State Center of Excellence for Cultural Competence and the Hispanic Treatment Program, and co-director of the Anxiety Disorder Clinic at New York State Psychiatric Institute. His research focuses on developing culturally valid interventions and instruments to enhance patient engagement, reduce misdiagnosis, and help overcome disparities in the care of underserved cultural groups. And we have Dr. Neil Aggarwal. Dr. Aggarwal is an assistant professor of clinical psychiatry at Columbia University and a research psychiatrist at the New York State Psychiatric Institute. He conducts research at the intersection of cultural psychiatry and psychiatric anthropology. His work has been funded by the American Psychiatric Association, National Institute of Health, and Substance Abuse and Mental Health Services Administration. Thank you so much to both of you for being with us today. The floor is all yours.
Thank you very much, Ari, for a kind introduction and for inviting us to present today. The topic that we will be focusing on is we called it the value of person-centered cultural assessment in clinical practice. And it's the first of a two-part series of this first set of talks, that the next part will be next week. And then, as you will mention later, there are 2 more parts to this whole series that will be presented later by other presenters. But these first 2 will be presented by Neil and myself. Next click, please. Neither Neil or I have any relevant disclosures to this talk. Next, thank you. The takeaway for the presentation is that including person-centered cultural assessment, and I'll describe in a minute what all of that means, person-centered cultural assessment in routine clinical care can contextualize clients' experience and enhance treatment planning and client engagement. Contextualization is a very important aspect of what we're trying to do, put the person's experience in some kind of context in order to understand it better. Next click, please. The overview of the main points we'll cover are the following. We want to talk about the goals of mental health assessment, then attempt a definition of culture and cultural competence, describe what we mean by cultural concepts of distress, describe social determinants of health, disparities, and structural competence, define, if you will, and illustrate all these terms and concepts, then go into individual cultural assessment. At that point, Dr. Aggarwal will take over, describe the beginning of some comments on the Cultural Formulation Interview, which will be expanded upon in the next presentation in a week, and then give some conclusions. Next slide, please. First, what are the goals of mental health assessment? And I should say that if you have any questions, please put them in the Q&A function, and we will have 2 time periods for discussion, one brief one in between our 2 presentations, and then at the end, hopefully more longer. So here is an attempt at some important goals of mental health assessment period, and in many ways of assessment, clinical assessment generally. It's not meant to be exhaustive, but these are some that I think are very important. I always start with the idea that part of what we're doing in an assessment is witnessing the person's suffering, being there as somebody who is accompanying the person in their suffering and evidencing that by the way we engage with them, the way we ask questions, the way we respond. It's very important. Technically, clinically, a part that in my profession, psychiatry, is most often emphasized is the value of an assessment for framing the person's account in order to manage treatment and course. We want to understand the person, but we also have a technical need to formulate the person's experience in a way that fits how we can help them to manage in some way. For example, in our case, we provide often medications. How do we frame the person's experience in order to decide whether and what to do about that? We want to establish a caring relationship, so there's a relationship building element, and we want to empower the person and foster patient engagement or client engagement. You can see just how many things we're trying to do at the same time, and what seems like a relatively simple, may seem like a simple thing, but it's actually quite complex. Next click, please. Here I want to pause and define these terms of medicalization and contextualization, because they are in some ways poles of an assessment that both, at least in our profession, often need to be addressed, but there are pros and cons to medicalization, which I wanted to mention, and to connect them with definitions of what is called in the medical anthropology literature, the concepts of disease versus illness. And this is the idea that a medicalized approach focuses on the disease processes, the pathology processes, and has important technical elements. I mean, in assessment, generally, you want to know what is the nature of the problem from a physiological, psychological, etc. perspective. And that's where the technical aspects of treatment and diagnosis come in. If you're a surgeon, for example, and these concepts of assessment are important, you want to know what organ is involved. But there's some pitfalls to medicalization, and our system too often emphasizes the diagnosis at the expense of the person's story, the person's own experience, lived experience. And that element of the what the person is going through, we label in medical anthropology as illness, as opposed to disease processes. And the illness has many more components than the diagnosis. You see here the person's own interpretation of what's happening, which is always involved by their affected by their cultural background. Their life circumstances. What is it that leads to the situation? What makes it better, worse? What are structural risk factors? Their position in a social hierarchy. How is that creating or worsening or perpetuating a presentation? The person's own experience of their life and lifestyle and choices and options. These are all important elements of what we call putting something in context, putting the experience of illness in context. Next slide, please. There are consequences, I just started to say, about decontextualizing. I realize many of you are social workers, and the whole approach of social work is to contextualize, but in psychiatry, we too often decontextualize, and that's where some of these slides are coming from. Not always, but we tend to do this. And there are dangers to decontextualizing in a way that goes beyond simple understanding in a kind of technical way, and that if we only understand in that technical way, there are problems by missing very important information of the person's context, and leading to great dissatisfaction often, when we hear that all the time from our clients. Possibly mistrust and miscommunication, both from lack of understanding and from the assumption, the experience of the person that we don't care. That's why we don't ask about their situation. We may encounter limited patient engagement. We don't really understand precipitants, mechanisms, prognoses if we don't understand context. And I suggest that it may be behind part of what's happening with clinician burnout, which is such an important point these days, because we are not, as clinicians, we may not be engaging the full person or being engaged ourselves in the work in a way that is fulfilling. And we may, by decontextualizing, lead to a higher risk of lawsuits. These have question marks next to them, because there's still issues to be discussed, if you will. Next, and to be studied. Next, thank you. There are many solutions to decontextualization. This cultural competence one that we're going to focus on particularly is one of them. There are many terms for cultural awareness. Some elements of humility may be favored in the definition, or in the notion of safety. I use the term cultural competence, and it's the name of the center that both Neil and I work in, because I feel that we should be placing the onus of what to do squarely on the clinicians and providers' shoulders, meaning it shouldn't be up to the person receiving services to become change their practice, change themselves in order to meet our practice, but it should be our responsibility to become, at least attempt to become, competent in the person's experience by changing ourselves and the way we do things. Competence is an aspiration. The idea is not that we will one day reach a competence level and never need to do anything else again, but it's something that we are aspiring to. Structural competence on social determinants of mental health is very important. I will mention that in a minute. And there are many other elements you see here. In the interest of time, I won't belabor them. Next slide, please. Now, what is culture and what is cultural competence? Next slide. Culture is a difficult word to define, and one difficulty in our country is that we too often think of culture as something that is internal to the person, if you will, and that is static and does not change, that are attributions of the person's own, if you will, traditions that are something that belong to that person. Now, culture is a process. Next click, please. The way we understand it for the cultural formulation approach, culture is seen instead of something static as something of a nature of a process. It's a way in which meaning and social practice are created. The person takes what they have inherited from their participation in multiple social groups, from their inheritance, if you will, of their cultural background, and recreates it in their own lives, changing things, making connections, the culture therefore for that process is fluid. It is very much contingent on the situation the person is in, with whom the person is speaking, what is at stake at a given moment for the person. For example, in terms of illness experience, the person may describe their situation very differently to their grandmother than to their minister, priest, rabbi, or to their high school coach, or their friends, or their clinicians. The cultural meaning that the illness takes varies over time and with different circumstances. Next click, please. So as a whole, therefore, culture is quite complex. The person's own culture is quite complex. And it's, as I mentioned earlier, an internalization of a social process where the person is engaged in multiple social groups at the same time. We have, if you will, different hybridities, different intersectionalities by being members of a certain age, a certain gender, a certain sexual orientation, a certain race, ethnicity, language, religion, occupation, you name it. We are at the intersection of all of these, and they all impact our cultural experience, and therefore what is meant by culture, that we're trying to assess the person's own experience of culture, if we will, in an individual cultural assessment. Next click, please. And this has always been the case. There is this, so I've heard this idea that in the past, it used to be simple and now it's complicated. It's never been this way. Now it's getting more complicated because people are connected at a much greater distance through social media, or they travel more easily, or their migration patterns. But it's always been the case that people are always intersectional, if you will. They are always connected to multiple social groups and recreating meaning and practice as they live day by day. Next click, please. So because this process is complex and varied and impacts illness and healing in such complicated ways, it is dangerous to stereotype and there's a risk of stereotyping if we assume that the person's culture is unchanging and can be easily seen just by looking at the person, that we can assume that a certain kind of racial or ethnic background or gender or whatever is necessarily going to behave and think and understand in a given way. It is something, click please, that instead we have to engage the person directly in order to understand their cultural perspective. Next click, please, the final click. And the difficulty is that engaging that person is something that you need to do not with a single question, but in a kind of process, which is why we have this proposal for an individual cultural assessment that's more of a process than a single question or 2 or 3 questions, because the person may not even be often aware of everything that they're doing that is influencing by their background. Most of culture, if you will, is unconscious. It's something we take for granted. It's how we behave. And as a result, we need to engage a person in order to see that. Next click, please. So this complex definition is attempted to be defined in the DSM-5 text revision, which just appeared this month, as these 4 points that are part of the introduction to the Cultural Formulation Interview, which essentially gloss the points that I've been making in the last slide. That culture is a process of meaning and social practice, that it's connected to the person's background and social context and position. It emphasizes, this definition in the DSM emphasizes the importance of the family and other aspects of the community, because these are the most important locations, if you will, groups of people through which individuals are enculturated throughout their entire life. And it also, in this last bullet, points to the fact that the providers, the system in which we work, are all contributors to the cultural situation in which the person is in. And therefore, we are also part of the picture of what needs to be assessed in a cultural assessment, what needs to be taken into account in understanding the person's own experience of illness. Next click, please. So what then is cultural competence? These are 2 definitions, one from the Department of Health and Human Services and one from the Office of Minority Health. If you click once, please, you will see that I'm highlighting in both definitions the fact that it's a set of things, cultural competence, in the case of the first definition, behaviors, attitudes, and policies. The second definition calls it multi-pronged. And the next click, please. And both definitions describe cultural competence as a set of these activities that come together in a systemic way. Yes, that is to say, not only in the activities of a given provider, but in a whole system, agency, or approach, if you will, of a healthcare system that needs to be taken into account. And then the definitions go on to describe the idea that these behaviors, attitudes, policies must come together in a system in order to enable effective work in cross-cultural situations. This is a definition of cultural competence. I would just add that every situation in this definition is cross-cultural in the sense that individuals all bring their various diverse aspects to the picture. And although what seems to be most obviously different from one perspective, they may come from different parts of the world, there are other ways in which difference can be expressed. And you see how the Office of Minority Health then adds some more operationalized bullets about suggestions of ways in which cultural competence can be described. Next up, please. So what are cultural concepts of distress? And why do I emphasize them? Next slide, please. Cultural concepts of distress are defined in DSM as ways that individuals experience, understand, and communicate suffering, behavioral problems, or troubling thoughts and emotions. Essentially, they are the ways in which people describe and experience their distress, which is always affected by their cultural context and background. That is to say, we don't invent our suffering in our own terms, but we are actually always understanding what's happening from a certain cultural perspective. Next click, please. And another way of describing that is as local forms of distress that depend on specifically culturally based attributions, responses, and interpersonal interaction patterns. Next click, please. And this is something that happens to all of us. We all express our distress in ways that we inherit and transform from our environment. Obviously, there are biological substrates to our forms of distress, but those are parameters around, sometimes fairly broad, around which our distress can be created, combined, expressed, understood in different terms. Next, please. And this concept of cultural concepts of distress is a way of replacing the older idea of culture-bound syndromes, which are not necessarily syndromes, and in fact are often not even psychopathology. They're just normal reactions. So I don't want you to take the idea from here about the replacement that it's only used, cultural concepts are only used to discuss things that seem exotic. It's actually the way we all express distress. It replaces this older term to encompass that older term and turn it from something that is more exoticizing, this culture-bound idea, into something that's much broader. And maybe this next slide, please, can explain this a little bit more. There are three ways in which we describe cultural concepts of distress in the DSM and related publications. And they are as forms of idioms, explanations, and syndromes. And the difference between them is that cultural idioms of distress are more general ways, linguistic and nonverbal, in which we express distress. For example, smoking is a behavioral, nonverbal way of expressing distress. They're the ways that we put together our experience. And these can be used, these idioms, to express a wide range of discomfort, including everyday concerns, subclinical conditions, or due to social circumstances rather than mental disorders. And they're not necessarily linked to specific signs and symptoms. For example, the whole concept of nerves, nervios, in Latin America refers to a general state of vulnerability to stressful life experiences and to difficult life circumstances that is not necessarily a single set of symptoms. It's more of a general combination, language of description. For example, to illustrate, think in the US of the terms burnout, which is acquiring great salience at the moment. People speak a lot about burnout. Burnout is an idiom that doesn't necessarily get associated with a specific set of symptoms. It's more an understanding of how the person fits, their life fits within a certain set of expectations, requirements, constraints that make the person feel bad in a certain way. So these are idioms. Explanations are labels, attributions, or features of an explanatory model that provide a culturally coherent concept of causation for symptoms, illness, or distress. For example, the way we attribute our suffering, our psychopathology, to any number of things, like stress is a cultural explanation for what we mean by the aspects of our lives that cause problems, or attributing them to spirits, for example. That's another type of cultural cause that we might be interpreting as a reason for why we feel distressed. The third one, cultural syndromes, are more like the DSM categories and the more general descriptions that we have in medicine about collections of co-occurring signs and symptoms with distinctive causes, courses, etc. But the difference is that for cultural syndromes, if you will, as opposed to DSM syndromes in a way, a cultural syndrome can be very broad, so that you can have a syndrome that is recurrent, patterned, if you will, stereotyped, but is not pathological, whereas it's actually a stereotype reaction to an acute event, for example, can be a cultural syndrome, but it doesn't have to be pathology. And one important element of all these concepts is that they typically signal a relationship with idioms of resilience, where people are often describing both at the same time, how they suffer and how they're trying to cope. And listening for both of them is very important because they can guide help seeking, as the final point makes. Next, please. So here, I won't, in the interest of time, go into great depth about this, but it's an illustration of a kind of cultural syndrome, a cultural syndrome that's present among Cambodian communities that I use to illustrate because Devin Hinton, who's worked on it a lot, has this very nice schematic that shows the multiple ways in which this kayal substance that is understood in Cambodian ethnophysiology as what's called a subtle substance, like qi in Chinese communities, or gas in some Latino communities. These are understood to be physiological concepts. Kayal is more like a wind-like substance that is maybe considered in traditional ethnophysiologies to be disrupted in the body and cause a whole series of symptoms. But the point that I want to make about Kayal here is just that it has a mind, body, ecology, and spiritual kind of connection, so that when the person is referencing these cultural concepts, they may be referencing all of the above at the same time. And we may only be hearing, for example, in psychiatry, we may only be hearing the medical physiology aspect and not everything else about the syndrome the person is trying to reference, including their relationship with their social world and the spirit world and the natural world all at once. Next, please. So as an illustration of the relationship between cultural concepts and DSM disorders, I wanted to show this schematic because the relationship is complex. It is never like the cultural conditions are DSM categories in funny dress. It's not like that. They are different types of conditions, and the process of communication between them has to be a process of translation, as if between different languages. For example, on the left there, you have a list of just some of the DSM categories. Next click, please. And on the right, you have a set of cultural concepts that are very common in the Latinx Caribbean. This forms a kind of a folk or popular nosology. It's not like there's a equivalent of an American Psychiatric Association that determines whether these fall into an official nosology or not. These are just the ways that people over the years have developed concepts and categories of distress. And you can see how many there are. These are just some, and how varied they are. Many of them refer to the concept of nerves, others don't. Some are widely known in the culture. For example, to be sick with nerves, estar enfermo de los nervios, is something that is extremely commonly discussed in the Caribbean where I grew up or in other Latino concepts. It's just a general type of condition that hangs together from a cultural perspective. Others, like facultades, faculties, are specific to a certain Latinx Caribbean subgroup, in this case, spiritists. Next click, please. And what I'm trying to show here is that the relationship between the two nosologies is not one-to-one, but one-to-many in either direction. So what makes a category like major depression hang together in a DSM official nosology of so many symptoms over so long with so much impairment can be different things from the folk nosological perspective, depending on attributes of major depression that aren't emphasized in the official nosology. Does it come in bursts? Is it associated with a certain kind of contextual precipitant that suggests it's a spiritual etiology? Any number of these are ways in which the single category of major depression can be understood as different categories under the folk nosology, vice versa. And next click, please. And as I was saying, vice versa. So that's something that hangs together as a kind of vulnerability, typically associated with certain future prognostic concerns and so on, like being sick with nerves, can be many different categories from the professional angle. And so next click, please. What we have to do, next click, one more. Thank you. What we have to do in a condition of trying to do this translation is understand the, click please, that the cultural concept falls, if you will, between multiple dimensions of a professional approach to understanding suffering, and that for any given person, you would want to know where they fall in this particular schematic. Are they in the very middle so that all of these domains are represented in that one person's experience of the cultural concept? Do they fall more to the right, so they're more sort of depressed and anxious rather than dissociative or somatizing? The same concept may refer to all of these, and we have to interview the person in order to understand both what the label of the cultural concept contributes. They usually a great deal of understanding of precipitants, social world, prognosis, and so on, as opposed to the technical elements that the diagnosis would offer. Both are very important. Next, please. And both should be part of a cultural, individual cultural assessment. And here you have these represented here in terms of why pay attention to this. Why is this important? There are many reasons. I won't belabor all of them. One that I like them, put it there first, is the idea that because we are aware of multiple languages, we become aware of the fact that the person experiences distress in their own way. It isn't a standard way that everybody experiences distress the same, but that how we label illness or distress is a product of a social interaction and a social concept of illness and cultural concept that we need to understand in order to do an interpretation process. It's not automatic, it's not simple. We need to understand what they mean in order to even understand what is going on from a professional perspective. That way it tends to reduce over-medicalization. Because the cultural concepts of distress are often connected to cultural concepts of resilience, it often, the path out of the distress is part of what the labeling it as a certain cultural concept of distress does, is part of that work, what it does by calling it that, by understanding it that way. It points a way forward, and understanding the relationship with resilience is important. Next click, please. And there are all these other ones that are more specific that have to do with research and the clarification of cultural conflicts that are understood when looking at particular cultural concepts that usually arise out of specific circumstances, and you want to know what's at play there, what's creating the problem at the societal level, for example. Next click, please. And then that's conceptually, and then clinically, there are many reasons also why cultural concepts are present. For example, people are much more likely to be screened efficiently if you use the concepts they use to express distress, as opposed to more culturally distant concepts. So nervios rather than depression or schizophrenia, for example, although depression is becoming more and more culture near. But there are a number of categories that are more alien to the person than the ones they use normally. We tend to avoid misdiagnosis because it's easy to get confused when somebody's using a cultural idiom. We often think they might even be psychotic when they're just using an idiom that makes sense in the culture, such as an idiom like witchcraft, but that we think may be associated with greater levels of severity, and so on. Next click, please. There are several reasons, including rapport, communication, even finding out the causes and what makes things work badly or well that can affect therapeutic efficacy. Next click. So briefly then, what are definitions of social determinants, disparities, and structural competence? Next click, please. Societal structure, click please, is an important, no, yeah, just one, thank you, is an important, very important element of how people get sick. Yes, that one, click, where you have public policies and social norms that create structural circumstances, next click, which affect the person's opportunity, their chances at opportunities and resources, next click, which then give rise to multiple social determinants of mental health because of the uneven distribution of these resources. Next, think of structural racism, for example, which then these social determinants produce reduced options, poor choices, so to speak, for people. Instead of choices, it's really options, is what that means. They make choices that are difficult because they have very few options. And behavioral risk factors, as well as stress responses of all kinds, next click, which then lead to adverse health outcomes. So these are social structural reasons why we have disparities in health and in healthcare. Next click. Now, a disparity is defined as the difference between across social groups of something, let's say, like quality of care, a disparity in quality of care that is not due to differences in clinical need or in the appropriateness or in patient preferences. If patients don't have the same levels of the illness, then they don't need the same level of care, for example. If an illness is much more prevalent in one population or another, or if it's not desired in one group or person than another. However, those preferences need to be genuine, not created by social structural circumstances of bad past experience. Next click, please. And so there you have a difference, for example, that is not a disparity if they're really due, for example, the reasons I mentioned a minute ago. Next click, please. But if you, and one more, but if you do have differences that are due to health system disparities, such as, for example, lack of insurance, lack of language access, these are disparities rather than differences, or any form of discrimination. So they are differences that are due to unfair practices that can be changed. Next, please. This here is only here to point out just how complex the multiple pathways and causes of disparities are, how it's not a simple approach, but rather we need a multi-level understanding. It's not just at the individual level, but a multi-level, systemic, institutional, larger societal structure level of understanding disparities, or we will not do a good job. The schematic, I won't go through it, it's just to tell you an example of just how many levels are usually involved in understanding disparities. Next click, please. And another element, and I use the term BIPOC, Black, Indigenous, and people of color in the term in the talk rather than minority. One, I see that the formatting is a bit off, but the idea being that despite the fact that there are great structural inequities in our society, the prevalence of mental health problems is not particularly higher among BIPOC communities, not as high as one would expect given the level of structural difference. And this is partly the reason why it's so important to focus on resilience elements, not just pathologizing elements, but communities have a great deal of resilience to overcome these structural barriers. One thing BIPOC communities do tend to experience is having more persistent, severe, and impairing disorders And this is partly due to the lower quality of access, service, use, etc., that are created by our system. So you see examples here in quality of care, initiation of care, and so on, which create a looping effect, so that probably because of this poor quality is one major reason why there's this risk of higher persistent and impairing and chronic psychopathology in BIPOC communities. Next click. So structural competence is a term that has been introduced because the cultural competence term has often been misinterpreted as focused exclusively on individual views and behaviors at the expense of larger context. Next click, please. And this new term shifts the focus from the individual to the level of communities, institutions, policies, laws, etc., that determine health. Our contention is that structural concerns have always been a topic of cultural competence. It's just that it's important to make sure that people understand that, and that cultural competence is not misunderstood in this static, non-contextual way as something that is inherent to individuals and doesn't have to do with the social context or social structural context. Next click, please. And so it's the structural competence approach focuses on systematic practices of exclusion, discrimination, and so on. Next click, in order to foster this change in the client, in the practitioner of this expanded scope of clinical intervention and responsibility. Next click, please. So here I'm going to stop, and we'll take maybe a couple minutes of questions or comments, and then I will ask Dr. Aggarwal Neil to continue the talk.
Doctor, we have 4 questions for you at this time. The first one reads, Dr. Fernandez, I appreciate your statement that competence is aspirational. Can you please elaborate a little more on this during the Q&A portion, which is now, especially in terms of how we can explain this to staff who may be resistant to this idea?
Thank you for the question. I will try not to go on for a long time. The idea of using the term competence, why I endorse it, is because I find that it, like I said, it is not a process that one completes, but it is a process but it's a process that is incumbent on the practitioner to carry out. And it involves not only an attitude like humility, but a set of other practices as well that involve in this tripartite definition of competence: knowledge, skills, and attitudes. So I'm a big one for the knowledge aspect of cultural competence. A practitioner should always be humble. In every circumstance. I mean, we don't know what the person is going through. We're not in a position to tell them what to do. I mean, we're there to help in any way that is possible. But we do have certain skills and knowledge that we can bring to the situation, including about their social, structural, and cultural background. And without some of that knowledge, sometimes we don't understand what the person is saying. The prototypical example that I tend to give is when in my training, I studied with a Puerto Rican spiritist in the Bronx, and she would always tell me about how people just don't know what people are telling them. Like people, because the spiritual world may be stereotyped and stigmatized in certain communities, including the medical community, the patient may not be explaining themselves completely on purpose, to see if we actually have enough knowledge about what they're saying before they say more. And if we communicate, and this was what the spiritist was telling me to do, if we communicate, we get their message, and we don't get their message if we don't know what to look for, then we are not in a position to receive the rest of the message. So it's an extreme sort of perhaps exoticizing example, but for me, it made a big difference in my life, which is why I bring it up a lot. It's the sort of thing that you need to know something in order to know the rest. And actually knowing something is a sign of respect. So it's very important not only to be a recipient, to do it humbly, but to do it with a training that we need to do in the skills and knowledge. And the skills is one of the things the cultural formulation approach, but aspirational in the sense that we never complete that training.
Thank you. And our next question, do you have any guidance for capturing cultural context in a crisis setting when the assessment may be limited or the individual may not be able to fully relate their own concerns?
I'm going to defer this question until later because some of what the cultural formulation interview attempts to do is to capture some sense of culture and context. And so maybe it's best discussed either at the end of today or at the end of the next time when we go through the cultural formulation interview. And I don't want to deprive Neil of the full time. And I'm wondering if we could maybe turn to Neil's presentation and then return to these questions later.
And for those that have submitted, we'll try to get every answer submitted in some form or fashion to you, so don't feel as if we won't address them at some time.
Thank you very
Doctor.
much.
May I weigh in on some of those questions?
Yes, sir.
For people who are interested in trying to make the point about why cultural competence is aspirational, I'm going to put in the link in the chat right now, a link of a paper that I wrote with colleagues, including Roberto. And by the way, you can call me Neil for this presentation. I'm Dr. Aggarwal in like a very different setting. But this is basically a paper that we wrote called Has the Time Come for a Cultural Psychiatry Fellowship? The reason why we believe, or at least I believe, speaking for myself, that cultural work is aspirational just because there's so much of it. I mean, every year I'm reading new papers on cultural adaptations to psychotherapy or case management. And to assume that simply imbibing the information that we give you today in an hour and a half, or that the collection of presentations that you'll get in 6 hours with this series, or that any kind of time-limited resource would be sufficient for lifelong practice, I think really misses the mark of where so many mental health practitioners are investing. I mean, people really are trying to grapple with providing forms of care like psychotherapy or medication management in culture compatible ways. And we see interventions emerging relatively regularly. So I think that makes the best case for all of us who are mental health professionals, who are peer providers, who are clinicians, to want to stay up to date on this scholarship. When it comes to capturing cultural context in a crisis setting, people may be interested in a paper that we published on how to actually do the cultural formulation interview in patients who are presenting to an acute emergency room and inpatient forensic as well as clinical unit. That link is right here. It's published in the Journal of the American Academy of Psychiatry and the Law. I saw in the chat that some of our participants have affiliations with mental health services that are administered through the criminal justice system. So I'm totally there with you in terms of how to think about culture across all different types of settings, all different types of populations, and all different kinds of sectors, including law enforcement and criminal justice, because it's no secret for any of us who do this kind of work that unfortunately many BIPOC individuals are involved in the criminal justice system. And whether or not they should be or what those charges are is a totally different matter that we can talk about outside of this. You know, if we were meeting at a conference, I'd say, well, that's the kind of discussion we have over drinks rather than in the formal presentation time. But we do know that BIPOC individuals are disproportionately represented in the criminal justice system. And the paper that I've put in the link, which is totally free, you don't have to pay anything to access it for that or for the other paper, that paper actually provides an evidence base for what clinicians thought about using the cultural formulation interview in an acute setting. So we believe it can be done. We believe it needs adaptations and guidelines that are based on specific situations and practice settings, practice environments, but I think that we can do that. And hopefully that paper will stimulate some interest in that direction. There is a great question that just came in the chat. In the cultural formulation, do you consider the person's religious beliefs? Absolutely. How? The short answer is we've got a wonderful set of questions through a supplementary module that I can put in the chat. Since I'm going to give my version of the presentation right now with slides, please indulge me until the main Q&A where I can look up the supplementary modules for religion and spirituality that may provide you with a series of questions that you can then kind of read, wrestle with, and adapt in your own clinical voice.
In fact, I think Ari and the team at the MHTTC have the supplementary modules, Neil. So maybe they could do it. They could put them in the chat while you continue your talk.
Perfect. I want to make 2 points right now. The first is I've been very fortunate to have federal funding for my research. And I have also been very appreciative of how taxpayers have funded the kind of work that we do. So in response, everything that we publish through our grants is available free of cost. So whenever you see our papers, they're not behind some paid firewall. So you can access all of our work on cultural assessment and cultural formulation interviews for free. And I'm saying that because I often felt frustrated when I was at other phases of my life where there'd be some information or papers that I'd want to read that would be behind paid subscriptions. And so you're more than welcome to access everything that we have. And we hope to build a community in that process with all of you. The second thing I want to say, and if you take nothing at all from my talk today or next week when I lead and Roberto co-pilots with me, the only thing I want you to take away is that we hope that you will see this process as an opportunity not to become experts in the cultures of all the people who come to you, because that would be impossible, infinite, and quite frankly, just nonsensical. We do hope, however, that you can become experts in the process of cross-cultural assessment and doing an individual cultural assessment. So we are explicitly not saying that this is a list of do's and don'ts for the Black patient, the Hispanic patient, the K patient, the straight patient, the transgender patient. No, we're not talking about that at all. We are talking about how one can do an individual cultural assessment. And with that, we hope to provide you with a series of concepts and tools so that way you can bring it into your life and clinical practice. Next slide, please. So to that point, what is a cultural assessment for clinical care? Because as Roberto mentioned, many societies around the world have their own concepts of distress and recovery. And we're not trying to ask you or anybody else to now become anthropologists conducting field work in different locations. We all recognize that our licensure and certification requirements really call us to fiduciary responsibilities of the person right in front of us. So we believe that it should be person-centered and that cultural assessment in clinical contexts is a process of, as you can read, eliciting, organizing, and interpreting information on the impact of culture and social context on the person's and the social network's views, practices, and resources pertinent to clinical evaluation and treatment planning. Now, that's a lot of words with more than 2 syllables, so let's break it down. We want you to elicit and get that information. We want you to organize it in a way that's sensible. And we want you to interpret it so that way it makes sense based on the frameworks that you use to understand the kind of work that you do, whether it's psychodynamic, whether it's cognitive behavioral, whether it's supportive, whether it's dialectical behavioral, whatever tradition you may belong to. We believe that cultural work can speak to you and the kinds of work that you do across those orientations. We want to see how that information relates to an individual's cultural factors, which we'll talk about in just a moment, and the social context, because if you're thinking about this in the way that I do, then we know that an individual might lie at the center of care, but then that person might be surrounded by close family or friends. And that person may then have a neighborhood, and then a community, and then a society. So we're trying to put the individual in an ecological framework. And the information we're specifically seeking is how they relate to other people. Because remember, culture is shared and transmitted. It's not just idiosyncratic or psychological. It has to be exchanged, it's created, and it's debated by the people who we all come into contact with. And what is created and debated? Those views, practices, and resources that people are bringing to the clinic. May I have the next slide, please? And we are going to advocate for a systematic approach to cultural assessment. An ad hoc approach is one that one can use kind of at will or maybe more idiosyncratically. There are also occasions that where that may be important, but we believe in the beginning, at least, that to do a cultural assessment, it should be systematic. May I have the next slide, please? And so this is just my slide to remind all of us that we want a cultural assessment to be comprehensive, meaning it should be getting all different types of information that we think are relevant. It should be thorough and not surface level. We want it to be standardized so that way we can see whether there are certain questions and responses work with certain populations or not, and that people can do it in a routine evidence-based way based on the existing data. It should be skills-based so that way you feel like you're learning and the other person is learning throughout the process. We definitely want it to be person-centered and not group-based, so that way we avoid stereotypes. And we want it to be educational. And by educational, I mean allowing for an opportunity of growth, whether it's emotional, behavioral, or ideational at the level of cognitions, for you, for the people who you work with, and even for that dyadic relationship in therapy, in the relationship, where both of you can learn how to discover new ways of being together in a constructive manner. Next slide, please. Now, as we've already seen from one of the questions, there may be people who perhaps sometimes raise skepticisms about why to do a cultural assessment. So why should we do cultural assessments? If Roberto's slides didn't convince you thus far, here are some other points. First, we know that culture really does affect the experience and expression of mental illness. So if anybody here has worked with folks who have anxiety disorders, sometimes people will tell me that they feel heart racing, or they feel chest tightness, so they feel it first in their body. Other people will tell me that they start to have these really scary thoughts that may relate to catastrophization. Some people feel like they get gripped by these really charged emotions. So what we now know through lots of work in cultural epidemiology and in cross-cultural psychiatry or related fields like psychiatric anthropology is that culture affects the way that people talk about their illness. Culture affects the ways that they feel it or experience it across groups. And culture also affects the words that they use. And we don't spend enough time, I think, in mental health talking about like positive strengths-based approaches, but let's try to do that right now with this presentation, which is it affects people's hope and recovery and resilience and the sources of meaning that they use for inspiration throughout life, whether or not they're in the clinic. Cultural assessments can also be really helpful in engaging the kind of translation that Roberto was describing a few slides ago between what might be popular nosologies on one side and then the DSM criteria on the other. Next clip, please. So that's a brief drawing of how we want to make sure that the information that can be really jumbled in somebody's head has an organized way of being able to bring it together. Next clip, please. The other thing that I also want to emphasize to people is that we have no desire whatsoever to contend that people need to read the DSM-5 before they walk into the office and that they need to be presenting in a particular way, or that we need to be recognizing that these presentations are consistent with the DSM-5. That's not at all what we're trying to communicate. We do know, for at least those of us who are providers, that we have certain codes like diagnostic codes and CPT codes that we all have to complete for billing. We also know that many people don't read the textbook before they walk in, or that many people have complex life phases or presentations. And a cultural assessment can really help to think about the behaviors, the thoughts that people are experiencing as reflective of some sort of underlying process that we want to unlock. So it's helpful in diagnostic evaluation, but it's not intended to reify or to assume that that exists and nothing else exists, that it can be decontextualized. Next click. And so can we have the next slide, please? And again, the one reason to do a cultural assessment is because one can get very rich person-centered information. And one can also obtain individual as well as close associate views. When I say close associates, I mean family, friends, or other people who might have some sort of meaning in their life, that it can obtain those views of illness and care. I say close associates also because for many months I worked on an ACT team where I had the real privilege of spending time with homeless folks who didn't really have any family or friends. And I also worked in situations at the VA where many veterans who I spoke with told me that oftentimes they had chosen kin rather than inherited kin. So if you hear me say close associates, it's because I'm trying to be as inclusive as possible and recognizing that kinship can be not just biologically based, but it can also be chosen. And so when we do cultural assessments, we're often trying to, at least what I'm trying to do, is listen for what might be the person's story, which is like, what is this illness raising for them in terms of the stakes of living? What kinds of problems is it causing them? In the DSM-5, then there's often a bullet point across all the criteria that these behaviors or symptoms must cause impairments in social or academic or occupational functioning, right? And if you ask people to tell you how this problem or the situation is causing difficulties for them, many people have great answers. And it's a fantastic way of being able to recontextualize what might be some sort of illness experience into the life world of the person sitting in front of you. The other thing that we often don't spend time talking about, but I'm going to put a plug in today, is that we can get a sense of how this individual sits within society and within structural forces in the world that they live in. So Roberto presented a slide on the social determinants of health. And sometimes when I look at that slide or when I look at the textbooks, it's like, oh my God, there's so many different boxes and there's so many arrows and something's going here and there. And then there are these bidirectional arrows. And it's like, well, doing a person-centered assessment can help to remind us that these concepts and theories are helpful, but ultimately we want to make sense of the person before us, not some group that they belong to that we assign some sort of identity to. Oh, they looked mixed, or oh, they look like they might be Black or they might be brown. But we want to get a sense from them directly who they are, how they live in the world, and what's going on with them. Why are they coming to see us? Next clip, please. We have seen in our work that using cultural assessments, surprisingly, and to me it's surprising because I didn't anticipate this moving in, but it surprisingly increases clinical rapport and trust. The therapeutic alliance between providers and patients is measurable. It's dramatic, and we'll present some evidence over this presentation and next presentation about that. It can also align provider treatment plans with what folks want in the clinic. So that way the treatment plans are consistent, they're patient-centered, and they reflect the values of the person who's coming in and ultimately would be responsible for working with you to implement them. Asking questions about somebody's life, as opposed to just, are you sad? Do you have a loss of interest in things you normally like to do? Are you feeling guilty, poor energy, poor concentration, poor appetite? Asking questions about who somebody is, what they're going through, who they talk to and turn to for support, to get a sense of what their life context is, we believe demonstrates caring in a clinical context. And it actually can bring up information about the kinds of immediate community, neighborhood, social, or cultural resources that people don't often mobilize when they think that the provider is not interested. We have questions that we ask that really get people to start to think about what they might be able to do inside and outside of the clinic to empower themselves. Next slide, please. And so, can I have another click? This is the difference between what we consider to be a generic mental health assessment and a person-centered one. Oftentimes, a generic assessment may include demographic factors that are pulled from the US Census categories. In a person-centered assessment, we really ask people to share with us what are the most important aspects of their identity. We ask them to think about it as plurally as possible, so they can say more than one identity, so that we get a sense of how that intersectionality relates to their life. In a generic assessment, most of the time people are engaged in just really doing symptom assessments. In a person-centered one, we're really trying to see how those symptoms are causing direct troubles for that individual in their life context. And we also ask about their experiences of discrimination, of structural racism. And so we're not just interested in what they may have to say or they may think that their brains are experiencing with symptoms, but to really embed that ecologically. Finally, in a generic assessment, most structures are often talking about living arrangements or food insecurity, but a person-centered assessment can supplement that with additional barriers to care, like, for example, being too afraid to walk in a neighborhood, or thinking about problems at work, or problems with migration and legal status. Next slide, please. Now let's talk briefly about the cultural formulation interview, or what we like to call the CFI for short. Next slide, please. And this is a set of interview, we call them protocols just because there are several of them, and we're still kind of figuring out as a research and practice community how to use which ones when, so that way there are semi-structured questions, but it's not rigid like a SCID or another very, very standardized interview. But we believe that these questions and interviews can really help to guide a cultural assessment during evaluation and treatment planning. We believe, and maybe it's an ideological approach and it's not evidence-based, but we really do believe that any provider can ask these questions with any patient in any care setting. They may not be able to ask all of the questions, or they may not be able to get the kinds of information that might be directly relevant to the question that is being asked. If, for example, somebody has acute fluid psychosis, or there are concerns about intoxication or cognitive impairment, but we believe that it's better to try first rather than not try at all. And the Center of Excellence for Cultural Competence, where Roberto and I both work at the New York State Psychiatric Institute, led the development of the CFI, and we tried to advocate very strongly for its inclusion in DSM-5. Can I have the next clip, please? It consists of several types of components. There's a core CFI that we typically refer to when we're talking about working with patients. There's an informant CFI that may be really helpful in situations where people may not necessarily be able or legally allowed to respond with full informed consent. So, for example, with children and adolescents, then an informant version can be really helpful. If somebody's experiencing acute intoxication or dementia and is not able to provide answers, the informant version can be really, really helpful in providing information. And then we have these 12 supplementary modules that are in the chat right now that Mordecai put in. And you can see a list of references. And since you guys are going to get a copy of the slides, you can look them up, and all of our work is available for free. So we encourage you, as a part of this process, if you're interested in this act of self-discovery through cultural assessment, to engage with our work. And you can always email us, and we're happy to respond accordingly. We take great satisfaction in knowing that we did a field trial in these different locations in 6 different countries across like more than 12 different languages with 75 patients and 321 clinicians. So we tried to make it as linguistically diverse as possible, as religiously, as caste and regionally and ethnically diverse as possible, as gender-based diversity would allow. We really tried to totally shake up the census categories to make sure that we weren't just following some sort of straight and narrow path. And we wanted to get as much diversity as possible to see whether the questions in the CFI would be able to elicit the most number of experiences possible that would be manageable in a field trial. Next slide, please. And the cultural identity, the cultural formulation interview, the CFI, is based off the DSM-4 outline for cultural formulation, which we often call the OCF. And it consists of these domains: the cultural identity of the individual, their explanations of illness, their cultural factors related to psychosocial environment and levels of functioning, which basically is like social relationships and kind of where they live and how they live. And then the cultural elements of the clinician-patient relationship. And so that's kind of what's going on in the room between us and the patients. And is that something we need to pay attention to? Do our patients have experiences of discrimination, being adversely treated in the healthcare system? You know, I work at Columbia. Columbia University was complicit in the slave trade when it was King's College and predominantly a merchant college in the late 1700s. We had, in our institution, used to make loans to slave merchants. We have a terrible legacy of slavery, of not just engaging in discriminatory practices, but of actually perpetuating them. Our sister institution, Barnard College, is named after a slaveholder who, after the 1790s, when there was a big faculty debate about slave owning, went on the wrong side of history and defended slave owning. So we still work in Harlem, and there are these conversations about the extent to which Columbia University extracts tax benefits as a nonprofit institution and does little for the local community. And it's not just this institution. I mean, the other institutions that I've been affiliated with, whether it's Harvard or Yale or other like fancy pants schools, all have these kinds of legacies that, if all of us are really committed to like anti-racist work, should kind of cause us to ask, well, how are the systems that we work in also carrying these legacies of disadvantaging people? And then finally, there's a fifth domain of overall cultural assessment. Next slide, please. And can I have the other click too, please? I'll just take them both together. So you've heard me talk about some of this, which is that we use 6 countries, 11 sites, 321 patients, 75 clinicians, 86 family members in the field trial. We try to revise those domains of the outline for cultural formulation into a 14-item beta version of the cultural formulation interview. We did a very systematic review of all cross-cultural assessments, interviews, questionnaires, and protocols that we could find from 1994 to 2013, just to make sure we weren't missing things. We came up with a standardized training approach, so that way clinicians would be trained in a consistent way. And that way, if you're familiar with like the psychotherapy training literature, we knew that they would be delivering the kind of right dose of all the right interventions in the questions, so that way we could minimize clinician variation. We use those results to revise the final version that you now see in DSM-5 into 16 questions. And we continue to do work on implementation, creating a fidelity instrument to make sure that clinicians have a checklist to make sure that they asked all the questions and did so in a great way. And we continue to do work on training. Next slide, please. And this is just a schematic of the kind of work that we did as a part of this process, where we looked at different cross-cultural assessments. For example, Canada, Netherlands, Sweden, the US, UK, Denmark, all had different types of cultural assessments that were based to varying degrees on the DSM-4 outline for cultural formulation. We crosswalked those and added additional materials from other kinds of cultural assessments in psychiatry, psychology, and social work to help produce the CFI that you see now. Next slide, please. Next click. And one more. There we go. And so we believe that the CFI, as I said, can be used by any provider in any patient with any patient in any setting. We like to encourage providers to kick off their evaluations or their initial intake assessments by doing the 16 questions. We've seen that many of the questions that get used in the social history can be anticipated in the CFI. If that's not possible, either because you don't want to, you don't think that it's important, we haven't convinced you enough, or because your institution has other kinds of practices, we believe that the CFI can be used really at any point in care to try to understand what the person in front of you is thinking. And then here are a list of indications of when to do the CFI. We talked about some of the cultural differences that may complicate diagnostic assessment and how, for example, there might be an unclear fit between what the person is saying and how that translates into DSM or ICD categories. Clinicians may oftentimes have difficulties understanding just how extensively a person's problem is causing impairments or severity in their lives, and these questions can be helpful. Sometimes folks disagree with us on what they think their care should be, and asking questions to that effect can be really illuminating for everybody. Sometimes people don't want to come into the clinic or can't come into the clinic, and asking questions about barriers to care can be profoundly valuable. Sometimes folks come into the clinic distrustful or ambivalent, and they might have different expectations about what should happen in the consultation room than we do. Clarifying that can be great. And as we all know, as I said before, sometimes services have really been engaged in forms of oppression, trauma, and discrimination. And this is our way of trying to move beyond that as providers. Next slide, please. Next click and next click. And so we believe that culture impacts all of these different domains. There are things that culture impacts, like risk factors or illness interpretations or types of coping before people come into the clinic for the initial evaluation. And then there are ways that culture intersects with people's care through treatment choice, goals, participation, and retention. And the CFI or other kinds of standardized cultural assessments can help you elicit that information in a systematic, comprehensive, and thorough way. Next slide, please. This is what the CFI looks like. To the left side are, under the column for the guide to interview, are instructions for clinicians. And on the right side is an interview guide. Next slide, please. And these are the 4 domains. We're going to talk about this more for our next session, so I don't want to spend too much time on it, but it's really how the person understands their problem. It's how they see the causes, excuse me, social stressors and supports, and the role of identity in relating to their problem. It then moves to thinking about cultural factors around coping, help seeking, and barriers to help seeking from the past. And then we bring it into the present to ask what their treatment preferences are now and what might be getting in the way in the current session with current clinicians. That could be barriers for all of us to work through. Next session, please. Excuse me, I said next session, I meant next slide. Next slide, please. So another click and one more, I believe. So these are the conclusions that I have for you, is that we simply think that good clinical assessment is patient-centered, and a good clinical assessment incorporates elements of a patient-centered cultural assessment. We've talked about cultural concepts of distress. And we've also talked about social determinants of healthcare and how that needs to be related to a good, solid cultural assessment for comprehensiveness. And we talked about the cultural formulation interview very briefly as a standardized approach to doing cultural assessments. Next slide. Now, in the last 10 minutes, any of you who have questions and answers are free to ask them. I'll ask Mordecai to moderate because some of you may have things in the chat that you've put that I haven't been able to check out yet, or Q&A questions that I haven't been able to check yet in the box. I want to leave you with one point, which is there are 145 people on the call today. Thank you very, very much. We don't take your time for granted. We are really honored that you're spending all of this time with us, and we want to do everything we possibly can to help you implement cultural assessments in your work.
And thank you, Dr. Neal. The questions that have popped up, there are a few. We'll try to take them all. First reads, can you talk about how the CFI can be used in an integrated behavioral health setting where there are several mental health providers?
Would you like me to take that?
Sure, why don't you take that, Neil?
I love that you asked this question, whoever asked it, because that's exactly what I've been trying to struggle with my clinical research, which is as we see mental health settings moving towards more team-based approaches, then we often see one person doing one type of work, like an intake, another type of person doing another type of work, like say maybe medication management, and a third person maybe doing psychotherapy. So what we're trying to do is figure out ways that we can take the information from the cultural formulation interview and incorporate that within the patient record. Now, there's no standardized way, and you can imagine that considering that there's 16 questions, there might be a lot of information to capture, and we want a good format to capture that information. But where I think the real change will come through is by information exchange. If you all are working in practice settings where you have an electronic health record, then the kinds of conversations that your organizations can have might relate to who does this EFI, at what point in care, how are they doing it, and how does that information then get communicated across other providers, whether it's in the electronic record or in case conferences or in other settings where providers can collaborate. But thank you very much for asking that question. That's like totally where I am psychologically right now on this work.
Our next question reads, how would clinicians support an individual who is experiencing a cultural syndrome if it is something that is not included in the DSM-5?
Maybe I'll take this one. I will try to answer briefly. The general idea of the cultural formulation approach and of cultural assessment more generally is precisely to get at the question the person is asking, or one of the reasons is to get at the question the person is asking. The question points out the limitations of a DSM type of approach in capturing all the ways that people express distress. Many are not included in the DSM system. So what the individual cultural assessment does is to, and the CFI in particular, is to elicit that person's experience. Sometimes, and often for financial purposes, for billing, for regulatory purposes, for determining treatment, we need to convert that, translate that into a diagnosis. But the translation process is what I've been trying to point out always happens. It's just that some of the expressions of people may actually be closer to the descriptions in the manual than others. But it's always a matter of translation because always some aspect is left out. The manual is schematic. It's a set of possibilities. A person doesn't have to have all of them. They always may have some and some that are not there. So an overly strict application of the manual is a wrong way to do it. It's essentially a guide to try to approximate understanding a person's experience and using a common language to communicate among clinicians with regulatory agencies and for treatment determination. So practically what you do is you find out what the person is experiencing using CFI or something else. And then you try, if you need to make a diagnosis using the manual, then you try to approximate that experience to the closest possible category in the manual without getting hung up on the idea that the manual is more real than the person. In fact, the person is more real than the manual. It's just that the manual is an attempt at schematizing person's experience. I don't know if that's what you were getting at, and perhaps others want to add or ask another question, follow up, but that's how I would approach it. The manual is always a schematic rather than a full picture.
There are a lot of great questions here, and in the interest of time, we'll take one or two more. How can this model not perpetuate the victimization some clients already have, and to help them get past this to becoming successful?
Neil, you want to take a shot at that? Do you want me to try?
I think the fact that we're talking about several themes like recovery, what their preferences are, how they see themselves and the world, rather than making any assumptions whatsoever, and really enlisting them in the process of developing, or what we call like co-constructing a narrative, is trying to mobilize the sorts of agency and recovery strengths-based approach that I was briefly touching upon earlier. We're not asking people to complete checklists. We're not asking people to kind of think of themselves only in terms of a diagnosis or a set of experiences. We're really trying to get a sense for how the person lives on a day-to-day basis. Like one way I think about the cultural formulation interview is culture or social structure or social determinants can just sound so broad and like highfalutin. Like I want to know how these things matter in people's everyday lives. Like what are the things they do? Who do they hang out with? Like, what are the activities they have? Like, what is the rhythm of their life like? And in doing so, we see that by asking open-ended questions and reminding people that there are no right or wrong answers and a non-judgmental stance, that we're trying to counter this idea of victimization that they may experience either in other aspects of their life with their close associates, or in other types of institutions, because we're really asking them to share with us, if they feel comfortable, what they think, so that way we can work collaboratively towards treatment planning.
Thank you. And our last question, in instances when there is a lot of hesitancy regarding documentation status, how would you broach that subject without triggering fear?
That's a great question.
Yeah, go ahead, Neil.
Could somebody, I mean, I don't know, whoever asked that question, could you say a little bit more, or could you type a little bit more? Because I'm very sensitive to this, because this question is very awesome. It's very good for a number of reasons. First, I do think that all of us who are providers should recognize that with current legislation, that folks have access to their treatment records. And so we want to be really mindful about what we put in the chart. And that means not just the chart that we use for psychotherapy with the individual, but also in recognition that that record may be read by multiple types of people. And so what I've often asked folks who I'm working with is, if I think that there might be information that is sensitive proactively, or if they tell me that this information is sensitive proactively, then I'll ask them for permission to be able to put it in the chart, or to not put it in the chart. And I also communicate to people that as a psychiatrist, society really does enjoin me to do a risk assessment. So if I think that somebody's acutely suicidal, acutely homicidal, or gravely at risk for being disabled and not being able to care for their activities of daily living, then I have to include the bare minimum information needed for that kind of assessment, or for that kind of disposition planning to occur. But short of that, then I think that we all have to get comfortable with the fact that the people that we work with may read those records, and we want to be mindful and respectful of making sure that we don't put anything that they would find unwelcome in that, because the process of therapy, as we all know, cannot be adequately captured just in like 1 or 2 paragraphs or 5 or 6 sentences in a record.
I would just add that I think underlying part of what Neil has said, that essentially some of that fear is well justified. And we cannot just assume that we can protect people from social situations that they might be exposed to by virtue of sharing certain information. So all that is very important for everybody in the healthcare system to be aware of. The person, the system you work in. We do work in a social system that needs to be taken into account.
Thank you all for your questions. Thank you, doctors, for your responses. Ari, I'll turn it over to you.
Yes, thank you so much again to our speakers for your time and expertise during this great presentation today. And also thank you to everyone for being with us. We're looking forward to our next session titled the Core Cultural Formulation Interview, Development, Research, and Implementation, coming up on April 14th to continue this great discussion.